learned a great deal. And I think that one of the things that F.E.A.S.T does very well is we, as caregivers, really play a role with either getting involved with food or being told to back off from the food. It's one of the intersections for us in treatment. And it's controversial, and it's still not something that everyone agrees on, but I thought we would have a session just on why is food medicine? Why do we say that? And why do other people say it's not about the food? Because it is, it's more complex than that. So Debra Katzman is here, and you can go on in your program and check out her bio. We're very honored to have you here for the day. If you didn't, she wasn't here yesterday, so I wanted you to approach her and meet her today. And let's get started.
Okay, well, it's really a great honor to be here, and I in particular want to thank Laura for this invitation to talk to you on why food is medicine. It's also great to see so many friends and colleagues in the audience who are so supportive of the cause and passion that we all have for eating disorders. So thanks, Laura, for this invitation. So how many of you out there believe that food is medicine? Well, I guess I can just go home. There's no need to talk about this. Exactly. Well, let's go through and talk a little bit about why it is so important that we use food as medicine. I'm hoping over the next 45 minutes or so, you as the participants will be able to appreciate why food is medicine, although you already know that. Understand the impact of an eating disorder on a young person's medical and psychological health. Appreciate the importance of food in the treatment of a child or an adolescent with an eating disorder, and then understand some about the energy that a young person needs in order to get better. So one of the things that I'm always asked about is why are eating disorders in children and adolescents so important? And my answer, I mean, and I don't have to convince the people in the room here, is quite obvious, but it's not obvious to everybody. First of all, eating disorders are being diagnosed in younger and younger kids. We just completed a study in Canada called the Canadian Paediatrics Surveillance Program, where we looked at kids who were less than 12 years of age, and we actually diagnosed kids as young as 5 years of age with an eating disorder. So this is no longer just a disorder between the ages of 15 and 25, with its highest prevalence during that age group. We are seeing younger and younger kids. The clinical presentation of children and adolescents are very, very different than adults, and people need to know that. They have significant medical and psychiatric consequences that are reversible if we diagnose early and treat aggressively. And as you all are aware, it has the highest mortality rate of any psychiatric disorder. In fact, children and adolescents are 10 times more likely to die than their healthy peers. One of the really interesting statistics that we've come up with is that the incidence of restrictive eating disorders in children under 12 years of age is twice that of the incidence of type 2 diabetes. Except that you guys hear about type 2 diabetes all the time. It's epidemic, right? I mean, that's what you hear. However, what you hear about eating disorders is that it's rare. I mean, go figure that. Now, the premise of this presentation is that food is medicine for children and adolescents with eating disorders. And I believe, and I know that you probably all believe, that nutrition is really the first line treatment for eating disorders. And I'm going to say that nutrition in this case is food for the most part. So therefore, food is really the first line treatment of eating disorders. Now, I'm going to follow up on something that Kathleen had talked about, and use this analogy of chemotherapy. When we talk about other childhood illnesses, we also talk about the treatment or the medicine for those illnesses. For instance, childhood cancer. Chemotherapy here is a lifesaver for many conditions like leukemia and lymphoma. And not giving chemotherapy can cause severe side effects, including death. Chemotherapy is necessary to treat young children and adolescents with cancer. But why don't we substitute the words food and eating disorders? Food is a lifesaver for eating disorders like anorexia nervosa and bulimia nervosa. Not giving food can cause severe side effects, including death. Food is necessary to treat children and adolescents with eating disorders. So why is food medicine? Is anybody familiar with the Minnesota Starvation Experiment? Okay. Well, as those of you who are familiar with it, this was a landmark study done in 1940, done by Ancel Keys. He took a sample of 36 conscientious objectors who had no history of a mental or physical illness. And the purpose of his study was to determine the physical and psychological effects of severe and prolonged dietary restriction, and to look at what nutritional rehabilitation did for these young men. So for the first 12 weeks of this study, everybody got 3,500 kilocalories a day. So everybody sort of started off at the same point. And then for the next 24 weeks, what they did was they severely restricted these men. The calorie intake was cut in half, and each man was to lose at least 25% of their body weight. They were fed cabbage, potatoes, and wheat bread. The physical outcomes of this semi-starvation was profound weight loss, low body fat, low body temperature, reductions in the respiratory rate and heart rate, swelling of the extremities, hair loss, and abnormal tingling sensations in hands and feet. Does this sound familiar to you of young people who have an eating disorder? Okay. What about the psychological ramifications or outcomes of starvation? Well, these men had severe emotional distress, including depression and irritability. They had mood fluctuations. They were preoccupied with food. One man said he talked about food and thought about it all the time. In fact, he collected as many as 25 to 35 cookbooks. Is this sounding familiar to you? These men had body dissatisfaction. They were stealing food. They had reduction in interest in sex. They were socially withdrawn. They were isolated. One man reported, "We became more introverted, more concerned about our own problems. Our thoughts were dominated by food." And they also had declines in their concentration, their understanding, and their judgment. Again, I think this is pretty clear. It sounds very much like the patients that I take care of and probably the people you know, including children and adolescents who have eating disorders. When they refed these men, they had intense hunger, and many of them had binge eating. And they were preoccupied, at least for 5 months into the refeeding period. And interestingly, and I want you to remember this, they needed up to 4,000 calories a day to gain weight. That may seem like a huge amount, but these young men were really hypermetabolic. They needed that food to get better. And so what Ancel Keys said in his conclusions is that the most crucial observation of the Minnesota Starvation Experiment is that the physical and psychological effects of semi-starvation during the study well approximate the conditions experienced by patients afflicted with anorexia nervosa and bulimia nervosa. As a result of the study, it has been postulated that many of the profound social and psychological effects of these disorders may result from undernutrition. And recovery depends on physical nourishment, that is food, as well as psychological treatment. So I think this really sets us up very nicely for the fact that food is indeed medicine. So how much does nutrition really matter? Well, without nutrition, young people with eating disorders develop medical complications. They're unable to engage in treatment. They're isolated. It's hard, really hard for them to work to get better. They have abnormal eating attitudes and behaviors, and they have mood changes. If you give them nutrition, you can help reverse the medical complications. They then are capable of engaging in treatment. They can reach out to others for support in treatment. They can work on getting better. You can help them normalize their eating attitudes and behaviors, and they develop a healthier mood. We know that starvation in children and adolescents with eating disorders lead to serious physical and psychological complications. In fact, every organ system in the body is affected by an eating disorder. If we look at the heart, for instance, the complications that occur in the heart occur early on in the illness. Not only is the heart's function, but the structure of the heart is abnormal. Young people have very low heart rates. They're at risk of developing abnormal heart rhythms, often life-threatening abnormal heart rhythms, and they have low blood pressure. Young people chronically can develop what we call mitral valve prolapse. If the heart is a muscle and you're not feeding it, it shrinks, and then the valves in the heart tend to flock over one another. That makes mitral valve prolapse. Many young people on a chronic basis will have fluid around their heart. And finally, I don't know if Ipecac you can get over the counter here, but we certainly can get it in Canada. It's a medication that some parents keep in their house should a child ingest something that's poisonous. Many adolescents will go to the store and buy Ipecac, ingest it to induce vomiting. Ipecac contains a toxic chemical that can lay down in the heart and cause the heart to enlarge. And there's no reversibility in that. A large heart, a cardiomyopic heart, can kill a young person. What's the treatment? Well, all of these things, except for the cardiomyopathy, are reversible with early identification and treatment with the slow, gradual weight restoration using food. Food is medicine. What about some metabolic complications that happen? Well, you know, when a young person is admitted into a hospital and you start to refeed them, they can get all kinds of fluid shift and electrolyte shifts, that's salt shifts that occur. They can develop things like low phosphate, which can actually kill you. And during the first week of refeeding, what can happen is all of these fluid shifts can happen and put a young person at risk. But after that, the refeeding syndrome doesn't end. What happens in the second week is you can get cardiac problems from refeeding. And after that, young people can become delirium, and that can happen in the second week. But with slow and gradual food restoration and weight rehabilitation, young people can get better. Food is medicine. Now, if we're looking at children and adolescents, as I said, are unique. They're very different than adults, and they have unique medical complications. These young people are still growing and developing. If you have an eating disorder during your childhood, you can impair your linear growth, you can stop puberty, you can develop low bone mineral density, otherwise known as osteoporosis. You can have changes in the way your brain forms and the way you think. But if you catch it early and treat it aggressively, you can reverse things. Now, what we know about linear growth is that the growth hormones, when a young person is really malnourished, don't respond normally. But with weight restoration, with food, these kinds of growth hormones turn back to normal, and the way they work, normalize. We also know that catch-up growth is possible when weight loss and stunting occurs before menarche, and when young people are given food non-stop, so there isn't a break with the refeeding. You can't give a young person food and then stop for a couple of months and then go back. You need to feed young people aggressively and continuously. Food is medicine when it comes to growth. What about puberty and eating disorders? Well, puberty can have a variable effect with respect to an eating disorder. If young people develop an eating disorder prior to the onset of their menstrual period, they can delay the onset of their menstrual period, they can delay sexual development. If they develop an eating disorder after their menstrual period, they'll have interruption or their menstrual period will stop. And this can have huge ramifications, which we're going to talk about in a moment. Now, menstrual dysfunction actually occurs across all eating disorders. Amenorrhea is probably most common amongst young people with anorexia nervosa, and this is associated with lower calorie intake, high exercise, and low body weight. Oligomenorrhea, which is defined as infrequent or light menstrual periods, is associated with binge eating, vomiting, and appetite suppressant use. So you can see no one is spared from abnormal menses when you have an eating disorder. And the causes are quite complex, and I would say not one of those things cause menstrual dysfunction, but all of them together. So you need a critical body weight in order to menstruate. There are studies that show abnormal eating attitudes and behaviors actually cause young people to stop menstruating. Excessive exercise, we know, can stop somebody from menstruating. And we know that things like depression and other psychological factors can actually prevent somebody from menstruating. And we know that in our patient population, anywhere from 40 to 60 people, 60% of the young girls that we see have a depression or an anxiety. So all of these things together can cause menstrual dysfunction. Abnormal menses is usually associated with low estrogen. And if you have low estrogen, you'll delay your sexual development, you'll have irregular menstrual function, you'll develop low bone mineral density, you'll have mood changes, you'll have daily or nightly sweats, you'll have difficulty sleeping, and you'll have cognitive problems. We also know that when we look at menstrual function, what happens to the body of a young person with abnormal menses is that their internal organs regress. Their ovaries shrink in size, and their uterus shrinks in size. And if I were to do an ultrasound on a young person who's 17 years old, who is menstruating normally, and show that ultrasound to an ultrasonographer, they would look at it and say, that is the ultrasound of a 5-year-old. What happens is the ovaries and the uterus regress to what they were prepubertal. But what happens when you feed these young people is that their ovaries increase in size and become more robust like an adult, and their uterus increases in size, and they start to menstruate. But they only start to menstruate when they're at 95 to 100% of their expected weight. And that's what the evidence shows. Food is medicine. The other complication I wanted to talk about was low bone mineral density, because this is a serious and frequent and early consequence of anorexia nervosa. Patients that we see have low bone mineral density even though they've had the illness for only 3 months. This may in fact impose lifelong limitations on these young people. It's associated with considerable morbidity, and by morbidity I mean disease. These young people are at increase for fractures. So on this slide here, what you see is age along the bottom and bone density along the left-hand side. And you can see I've marked the adolescent period. From birth until just a little bit after adolescence is the time that you are going to increase your bone mineral density. If you develop an eating disorder, and we know that the most common time to develop an eating disorder is during adolescence, what will happen is you will not reach your full bone mineral density potential. And when you go into menopause, you are potentially starting with a lower bay, and you're at increased risk for all of these terrible complications. We know that the mechanism for low bone mineral density has to do with the hormones in the body, the growth hormone, which I told you about, the low estrogen, which these young people have. It's also associated with low weight in and of itself. So people with low weight, even if they didn't have an eating disorder, if they had another disorder like cystic fibrosis or inflammatory bowel disease, have low bone mineral density. And we know that these young people aren't taking in enough food, and probably have very low calcium and vitamin D intake, all of which are really important for bone. What we do know from the literature is that greater than 90% of adolescents have low bone mineral density at one or more skeletal site, and very, very early on in the illness. We also know that adolescents with anorexia nervosa in particular, during the time that they're in the throes of the disease, do not put on bone. They flatline. There's a lovely study that shows young people who have had the illness for a year, they monitor their bone mineral density over that year, and they did not get any bone. We also know that low bone mineral density that's acquired during adolescence may have lifelong implications, including increased fracture risk. And the only way we know how to treat this is with weight restoration. The studies have shown over and over again that the best treatment is weight restoration using food. Many people think that you can give these young people estrogen. It is not helpful. Weight restoration, weight rehabilitation is what helps the bone mineral density of young people with eating disorders. Food is medicine. What about the brains of these young people? Well, we know that in adolescence, this is a really important period of time for brain and cognitive maturation. There are 3 important matters in the brain. You've got your gray matter, your white matter, and your cerebrospinal fluid, the fluid that your brain is bathing in. We know that during normal adolescence, there's increases in both the total white matter and gray matter. And we know from studies that we've done that starvation and anorexia nervosa can compromise this development. We did some studies looking at young girls during the acute phases of anorexia nervosa. What they had were increases in their cerebrospinal fluid volumes and decreases in their gray and white matter. And when we looked at them when they were weight recovered, what we found was that weight, food, nutrition, rehabilitation helps. It actually helps reverse this, but if you don't identify this quickly, if you don't treat it aggressively, there are still deficits in both the gray matter and the cerebrospinal fluid. So here's a picture. Now on the bottom here, what you see are healthy adolescents, 14, 15, and 16 years of age. If you look at those two things that go like this, these are the ventricles, and that's where the fluid is. You can also see some of the lighter stuff around the brain, that's where the fluid is as well. If you look above, you can see a 14, 15, and 16-year-old girls with anorexia nervosa. I think you can appreciate there's lots more fluid in those ventricles and around the brain. That's what it looks like. So lots of people then say to me, so what exactly does this mean? Does it impair their thinking? Well, we've done longitudinal studies on young people who have had anorexia nervosa as adolescents and followed them into adulthood. And again, if you don't weight restore them, if they don't resume menstrual function and have estrogen circulating, what can happen is that they can have long-term effects to their learning and memory, to their attention, to their visual spatial abilities, to their executive functioning, which means their ability to plan and organize, and their ability to abstract thought, that is to generalize. So you can see this can have a huge impact on the way kids think. Food is medicine. Now, if we look at weight loss in these young people, we know that patients, let's just use anorexia nervosa for now, when we see them, when I see them, many of them are eating less than 200 to 500 kilocalories per day. And when we go and explore more about what they're eating, it's relatively low fat, higher in carbohydrates, and probably normal to low in proteins. Many are vegetarian, or else they're not eating red meat. They often have similar food choices every day. They're calorie counting or fat counting. And often, many of these young people have ritualistic behavior around their food. Now, if we were to look at a healthy adolescent, and this is an adolescent who's just sort of not doing any exercise, just sort of sitting around all day long, would require about 65 to 90 kilocalories per pound per day to maintain their weight. So that translates into, if you had a 110-pound adolescent who was fully grown adolescent, not doing any growth or development during that time, they would require, just sitting to maintain their weight, about 1,500 kilocalories per day. Yes?
Is this boys or girls?
It's a girl. Thank you. Boys would be about 2,000 kilocalories a day if they were just at sort of their basal metabolic rate. Now, a patient with anorexia nervosa would need significantly more. A patient with anorexia nervosa who is 85 pounds would need about 4,000 kilocalories a day. And the reason that I point this out to you is because I know that many parents are often shocked, as are the young people, at the amount of food that they need to eat in order to get better. But they do need to eat a lot of food. Now, adolescents with anorexia nervosa are what we call in a hypermetabolic state. That means their bodies require more energy to function, and this can happen for at least up to 2 years after they achieve their target weight or their progress weight or whatever weight you want to call it. It's not unusual for them to need anywhere from 3,000 to 5,000 kilocalories per day. Now, that's a young person I'm talking about who is fully grown. But what you have to put on top of that is most of the kids that I see are going through growth and development. They're going through puberty. So they need a lot of energy in order to meet their demands in terms of puberty, but also to meet their demands in terms of what they need in order to gain weight with an eating disorder. So how do we approach this? Well, if I put my pediatric hat on now, and I think about how to approach a problem that requires medication, what I first want to do is identify the problem that I'm dealing with. I want to specify the therapeutic objective, what I want to see as the end result of that treatment. I want to select an appropriate drug to treat that. I want to initiate therapy with that appropriate details. I want to give information and instructions and warnings, and then I want to evaluate my treatment. So let's simply just go with an ear infection, because most of us are familiar with either a child or themselves who have had an ear infection. So I identify the problem, it's an ear infection. The objective of my treatment is to get rid of the infection. I want to select an appropriate drug therapy. In this case, I'm going to treat with an antibiotic called amoxicillin. I'm going to initiate that therapy, which is about 500 milligrams a day, 3 times a day. I'm going to give information and instructions and warnings to my patients and families. They may get some stomach upset, but they need to finish all of the medication. And then I'm going to evaluate their therapy regularly. So the parent needs to evaluate the fever, the pain, see the patient at completion of medications, and evaluate the ear. I mean, that's pretty standard. Okay. Now let's substitute medication for food and nutrition and an approach to an eating disorder. So first let's look at anorexia nervosa. So identify the problem, it's anorexia nervosa. I'm going to specify the therapeutic objective. Initially, weight restoration. I'm going to select the appropriate drug therapy. Food is the medicine. I'm going to initiate therapy with appropriate details. So I'm going to suggest for this young person, they have 3 meals and 3 snacks a day. I'm going to give information and instructions and warning. Parents need to support the young person and be involved, and we need to closely medically monitor this young person. And then I'm going to evaluate the therapy regularly, and that depends really whether the patient is an inpatient and outpatient. You'll evaluate differently. Okay, let's look at bulimia nervosa. I've identified the problem. It's bulimia nervosa. I'm going to specify the therapeutic objective, reduce or eliminate binge eating and purging. I'm going to select the appropriate drug therapy. Food here is the medicine. I'm going to initiate therapy with appropriate details. 3 regular meals and snacks a day. And I'm going to give information and instructions and warning, parental support and involvement, and close monitoring. And again, I'm going to evaluate therapy. The evaluation will depend on whether the young person is an inpatient or an outpatient. So how do we do this? I'm going to take you first into the inpatient unit, because I think this is pretty important. Most of the kids that I see, we try and treat as an outpatient, but many need to come in to initiate weight restoration. And that's okay, but the one issue with weight restoration when they come into the hospital is that the doctors and the nurses are initiating weight restoration. So we want to do this as quickly as possible so we can get these kids out of the hospital so that their parents can take charge and not us. So there was one really nice study that was done by Andrea Gartner about 1.5 years ago, because she was actually the first person to actually look at weight restoration when you admit kids to hospital and how to do this safely and quickly. She started most kids off at 1,200 kilocalories, and what she found, interestingly enough, that kids lost weight the first 8 days of hospitalization. So you're wasting 8 days of a kid in hospitalization. We just had that talk about insurance, and we're not feeding them enough. And it prolongs the hospitalization, and it prolongs the kids getting back with their parents. So I'm sorry you can't see this very well, but we initiated a treatment protocol based on Andrea's work, which I think was excellent because it was all motivated to look at better treatments and quicker hospitalizations. And instead of starting off at 1,200 kilocalories, we started off at 1,500 kilocalories, and this is what happened. The kids came in, and we started measuring from day 1, and what you see after day 2 is that each and every one of those kids gained weight up until 2 weeks, when we could start discharging kids from hospital. So this was a quick and also underlined a safe way of getting these kids to gain weight. None of them had medical complications associated with this, like the refeeding syndrome that I talked about before, where there were lots of fluid and electrolyte shifts, but this was safe, and it really did help put on weight. And we're going to continue looking at this to see whether or not we can even up it a little quicker, so to get kids out of hospital as quickly as possible. So the whole idea here is we don't want to delay treatment. Kids need to be diagnosed quickly and treated aggressively because we want to delay any possibility that these kids could develop medical, psychological, or social complications. Because if you do diagnose quickly and you do treat aggressively, these things are completely reversible. Why is it important? Because we want short hospitalizations for our kids. We want to get them into treatment as soon as possible. We want to begin the family-based treatment as soon as possible. Parents need to get involved as soon as possible. So, did I convince you? Yeah. I can open up for questions now. These are just your take-home points. Yes?
How do you explain the variation in loss of menses in young women who can have profound weight loss and have very low body weight yet still not meet that criteria or meet that that presentation? Which I think, I'm not actually, don't quote me on this, but I'm not positive, but I know that it's always been in the DSM. Yeah. For diagnostic criteria, and yet there are a population of young women who don't meet that, despite the fact that they're profoundly low weight.
Well, I think you'll be happy to know that the DSM-5 is coming out in May 2013, and we're getting rid of the amenorrhea criteria. So that will no longer be one of the criteria we use to diagnose young people with anorexia nervosa. It is curious. I'm not sure that we have the answer for that. I think some people just have a lower threshold or a lower weight that they can menstruate at. That's the best I could do. Yes, Kathy?
I would add, too, that they're not necessarily having regular ovulatory cycles.
That's true.
Some of it may be estrogen withdrawal, and some of it may be confabulated menstrual cycles as well.
Yes. Yeah, that's a good point. Yes.
Oh. Sorry, I understand. That sounds good. Yes.
My daughter, she was diagnosed at 9. She stopped eating at 7. She met every single criteria that you cited. She's had, her growth hormones were disrupted. She's now 14. She's on growth hormone. She had vitamin D deficiency. Luckily, she didn't have any problems with her heart. But we diagnosed it very early, and we went straight to family-based treatment. And she still struggles. We still, my heart is pounding because I don't think that she's got enough caloric intake right now. But it's amazing to see, how she followed that exactly. Her menstrual cycles are still not there. She would get regular bone density tests on her hips and her wrists because she does have that problem. She's even, there's nothing medical to prove this, but she also has some scoliosis, so she's wearing a brace, and there's possible that she has propensity, and because of her erratic growth, maybe had she grown properly, she would have straightened up faster. That's a non-medical thing that I'm saying, but she's had problems with her growth and her bones, and she's eating well now. She's out of the woods, but it had a profound effect on her growing from the ages of 9 to 14, and she's still struggling with it. But I think with early detection, like you said, and us being very proactive, that she's going to be fine. That when she gets past puberty. So I just wanted to tell you.
Thank you for that comment.
Statistics.
Yes.
Why are some children not hypermetabolic and some are? Does it relate to how early the disease is caught?
Yeah, I guess it depends on when the disease is caught and how much weight they've actually lost. So most of the young people that we do see, once you start feeding them, even though they've lost maybe a little bit of weight, they do become hypermetabolic for a certain period of time. And that may not last as long as somebody who's lost a significant amount of weight for a longer period of time. But all of them do. I mean, the body does tend to, when you're restricted like that, when you begin to refeed it, it does become hypermetabolic for a short period.
So maybe the reason I feel I didn't see it is because my daughter's so little. I mean, she's 7, and so the amount of food she needs just isn't.
It wouldn't be the same as what I've shown here. It would be significantly different because she's probably not yet gone into puberty. I mean, what you've got really is a double whammy when you've got kids who develop anorexia nervosa in the throes of pubertal development. You've got to deal with hypermetabolic issues of anorexia nervosa, plus you've got to do the catch-up that you need to in order for them to grow and develop. And lots goes on. I mean, you've got you need to grow in height, you need to grow sexually, your brain is growing, all the bones in your body are growing, so there's a lot of things that are going on that require fluid, fuel, right? Right. Yes.
What guidance or words of wisdom do you have for parents who are in the process of refeeding their children? And the children are experiencing, you remember like the stomach upset you were talking about with the amoxicillin, that they're experiencing the distress.
Yeah.
And of course, you know, a parent is very afraid of refeeding syndrome. And so just guidance about how to not be too frightened by that.
So the refeeding syndrome is a little bit different than what I think you're referring to as the distress. And what I always tell my own patients is that that distress is actually very real. When you are refeeding a young person who hasn't seen food for a long time, their transit time, the time that it gets to their belly and through their gut, is slowed down significantly. And that can last for months. So what they're actually experiencing is very real. That doesn't mean that you can slow down or decrease their intake. You've got to sort of work through it. Acknowledge it, acknowledge that it's real, and acknowledge that it will get better. There have been a number of studies looking at ways in which they can increase that transit time from the time it hits your belly to go out, so you don't have that sensation of feeling really full all the time. There are medications that have been used, but they're no difference in terms of just doing it naturally and feeding through it. So what we recommend to our own patient population is bite the bullet, parents support the kids through it, it is going to get better. When you talk to kids after they've done it and they've been through it, they do reflect back on it, and it was a real problem, but it was real helpful. Yes?
I want a little clarification on the brain issue. See, I hear you say that some of the brain changes may be non-reversible. I have a child who's been in recovery, I mean, truly weight restored to the 76th percentile, which is where she always tracked healthy. But she was one of those 9 to 11, hit puberty on the, gained 40 pounds, boom, puberty at 11. But she has had, we believe from her IQ and everything, significant drop in short-term memory. So, I mean, with my husband and I, until I heard this, we could think, maybe something messed her up, when she was underweight. And have you seen that happen, like in the short-term memory specifically? And is it reversible, or is it something she does not have to deal with for the rest of her life?
So again, this is a complicated issue, and I'll try and take it in steps. The jury is still out as to whether or not the functional things that you saw, the brain compartments, the fluids, the white matter, the gray matter, are completely reversible. The studies that we've done, we're not confident that they are completely reversible. However, there are studies that have been done in other groups that have found that they have been completely reversible. So I think that we need more studies to confirm what happens to these young people. There's only one study looking at adolescents and their cognition and following it to adulthood, and that was the study that we did. And essentially what was important about that is that kids who gained the weight and who also started menstruating normally, and I mean really normally, having a menstrual period every month, were the young people whose Cognitive function, when we compared it to age-matched controls, kids who were the same age and at the same grade level, were very, very similar. There was no difference. It was the kids who were not weight restored or the kids who were not menstruating normally that had differences in their cognition. When we looked at it more closely, what really came out of that was that menses, in particular, estrogen, was really, really important in terms of a young person's ability to think clearly, to have all of those neuropsychological domains to be within the normal limits when compared to other kids their own age. And if you look at other studies, for instance, kids with Turner syndrome, and I don't know if you're familiar with kids with Turner syndrome, but these are young people who have, who don't necessarily have normal ovaries, and they don't produce estrogen. They find the same thing in these kids. If you give them estrogen, their brains work better, okay? And similarly, you find this in women who have had their ovaries removed for some other reason. And there may be some people in the audience who are giggling and laughing that when you go through menopause, you also have some experience with cognition. And it is truly related to, I think, in part, estrogen.
We've talked a lot about amenorrhea, but there are parents here with sons. Is there any research about the hormone connection with young men?
So with respect to young men, and that's a really great question, there...
Couldn't hear what the question was.
We're talking a lot about estrogen in young girls. What about hormones in boys? And that's a really good question because there's lots of questions about what happens to these boys' bones, what happens to their brains, that kind of thing. I don't have the answer with brains, but I can tell you with bones, boys who have eating disorders, in particular anorexia nervosa, also have low bone mineral density. And our group and the group at Mass General have done studies on this to look at this. The group at Mass General did a small study, not published, looking at giving testosterone. But the sample size was so small, you couldn't make any heads or tails of whether or not giving hormone actually helped their bone mineral density. I can tell you one of the things that we're pretty passionate about when we talk about hormones, and I'm sorry to go back to girls again, but there is this, this message out there that if you give young girls with eating disorders who are not menstruating estrogen in the form of an oral contraceptive pill or a small dose of estrogen or whatever, that you're going to increase their bone mineral density because, of course, estrogen is really important to bones. And I can tell you there are numerous studies out there which show the same results. Estrogen in the form of a pill does not increase one's bone mineral density. What it does is it may give a young person a menstrual period, and as Kathy had mentioned, when we were talking about factitious menstrual periods, what happens in our population is we get kids coming in on the oral contraceptive pill and them saying, I'm menstruating, I do not have to gain weight. So we encourage physicians and gynecologists and pediatricians who see these young people to not put young people on the oral contraceptive pill. We've done one study right now, which has been published about 6 months ago. It's a huge cohort study, our center with the Mass General Hospital, looking at the estrogen patch. And the estrogen patch works differently than the oral contraceptive pill, and the estrogen patch does look much more promising in terms of enhancing bone density. But this is a study of one. And I just want everybody to be cautious. I don't want everybody running out and asking for the patch. But I'm just telling you that we're moving forward with understanding a little bit more about eating disorders and really good treatments for eating disorders and all the medical complications. Yes?
Is there a place where these studies are posted so that we could refer to them or send our friends, colleagues, doctors to refer to them for reference about this recent information that you're referring to?
I don't know that there's one place for it, but I could certainly...
But F.E.A.S.T is hoping to
right, and
do a booklet on this very topic
right
in first part of next year.
There you go. So we'll... There you go. Okay, one final question because I have 1 minute. Okay, go ahead, Ms. Craig, and then we'll.
So when my daughter was released from treatment, they said she needs to undergo the program and whatnot. So this is the first time I'm hearing more about this family-based therapy. I was also taught for years it's not about the food, it's about there's emotional problems or whatnot. So what I'm hearing here is promising. It is about food. But what's the right balance between it is about food and it is about all of the therapies, the emotional aspects?
Right.
So how do you gauge that?
So I've only done the very first part of treatment. And I hope I premised things by saying that this is really the first part of treatment. You're not going to be able to really engage a young person in treatment unless they're better nourished. So this is the first part of treatment. The harder part of treatment is what comes next. And that's when you engage them in the best treatment we have, which is the family-based treatment. So as soon as you can get kids eating, and I'm just talking about hospitalization, family-based treatment is treatment that's done on the outside. That's an outpatient treatment. That's what parents do and do it very effectively. And if you can do that in cohort, that is the treatment. So if you can do that in cohort with your therapist, doing the feeding and the therapy together, I think you're in good shape. And I guess what it really says to me, and I hope to the rest of you out there, is that this is a complicated illness. It's not just only about the food. Food is the medicine. It's about a whole bunch of things, including the therapy that these kids and the families desperately need to get their kids better. I'd be foolish to stand up here and say it's only about the food, because it's not. Okay, thank you so much.